So the next question is image based question. Identify the marked liver segment. This image has been picked up from the internet. I found the exact image on the internet. Now some segment has been marked. Now you should know what it is before that, but it's a tricky question, right? It's not easy because depending on, it's a CT picture, so what level the transverse section has been taken, has been shown, the orientation of the liver segments will change. I'll just show you. So just a simple anatomy, the anterior view and the inferior view. As you can see, the anatomical division and the surgical division of the liver. Anatomical division is done by the falciform ligament. The surgical division is known by, very important again a question, Cantley's line. Cantley's line, it's an oblique line 75 degree to horizontal, and it joins the gallbladder fossa, that's the gallbladder fossa, to the left side of IVC or the middle hepatic vein. So you should know how the Cantley's line is drawn. So, and this is for surgical division of liver into right and left. Now the segment 1, it's on the back side of the liver, behind the liver, and it's embracing the IVC. That's the autonomous segment, also known as Spigelian lobe or caudate lobe. Now these are the CT pictures. Now this is a superior cut or upper cut, and this is inferior cut or lower transverse section. How do you make out? Now in this you can see some surrounding lung shadows, whereas in this you can see the renal shadow. So when renal shadow is coming, that means it's an inferior cut, whereas if there is no renal shadow, in fact some diaphragm and some lungs are coming up, it's a superior cut. Now when it is a superior cut, this is the orientation of segments. Segment 2, 4A, 8 and 7, and that's the segment 1. But if it is inferior, it's easy, that's a sequential 3, 4, 5, 6, right? So it's easy to remember the lower cut, but the upper cut, the orientation changes, you can compare. Now it's 2, 4, 8 and 7, right? Now see, go back to this picture, you can see the renal shadow, so it's an inferior cut. So the orientation will be 2, 3, 4, 5 and 6. So it's a segment 5, right? So that makes a difference whether it's superior or inferior cut. This was the picture I found on the internet, and exactly this picture, as I was told, was given in the exam. So that's the orientation of the segments. Next question, which of the following is false regarding acute cholecystitis? Again, relatively easy question. Now positive Murphy's sign, that's true. All of you know Murphy's sign, it's a palpatory finding. You examine the abdomen, insert your fingers under the right costal margin. During inspiration, the fingers goes deep into the abdomen. During expiration, as the gallbladder comes out, inflamed gallbladder touches the finger of the examiner. Patient winces in pain and there is a catch in the breath. So that's a positive Murphy's sign in acute cholecystitis. Gallbladder wall thickness more than 3 millimeter. That's again a diagnostic feature of acute cholecystitis. So that's true. Leukocytosis may be seen with acute cholecystitis. So automatically that's a false statement. Preferential gallbladder visualization. In fact, non-visualization of gallbladder is suggestive of acute cholecystitis. Though HIDA scan is good investigation to diagnose acute, but it's expensive and not available everywhere. An ultrasound is good enough. So, but theoretically HIDA scan, if you do for acute cholecystitis, non-visualization of gallbladder even after 4 hours of giving the contrast, that's the feature of acute cholecystitis. So that's the answer here, that's a wrong statement. Now another clinical situation, 24-year male alcoholic presents with severe abdominal pain and fever for 2 days. So short history of pain and fever, suspected to have pancreatitis. So the examiner has already given you the diagnosis. CT shows large abdominal collection with the pancreatitis. So diagnosis is there in front of you. So it is acute necrotizing pancreatitis. There is pancreatic necrosis, there is large abdominal collection, patient has fever, so it's likely to be infected as well. And blood pressure 90/60, so hypotension, in spite of the fact that patient is on vasopressors. SpO2 is okayish and TLC is raised, so again indicative of infected collection, and infected collection needs drainage, urgent drainage, and lactate is 4.5. So patient is hemodynamically not stable. So that's a crux of the story. The situation is acute pancreatitis with large collection, hemodynamically unstable patient, right? So let us see the choice of the treatment. So obtain culture, it's again a multiple correct question. So obtain culture, yes, culture is needed. Whatever you do the blood culture and aspirate, send it for culture. Then broad spectrum antibiotics, definitely it's a clear cut infected collection, infected necrosis. Intravenous fluids, and so obviously fluid and drugs resuscitation will be needed because patient is unstable. MRI to identify the ductal anatomy, does it really help in the immediate management? Patient is hemodynamically unstable, diagnosis is relatively known. So knowing about the ductal anatomy at this moment is not required, can be done at a later stage, but not the part of early treatment, early management. Image guided drainage of the collection, that's the most important. In fact, if you have to choose one, then this is the most important, right? Important, not the most immediate. Image guided drainage of the collection, right? So because it's an infected collection, ultrasound or CT guidance, you need to drain out the fluid, put a drain into it, a catheter for a continuous drainage. Laparotomy and pancreatic nephrostomy, no way, because patient is unstable hemodynamically, plus many patients of acute necrotizing pancreatitis, if they respond well to the antibiotics, just with the drainage of the collection, they might respond and you might not need. So necrostectomy is not needed in all the patients, only at a later stage. If patient doesn't respond to any of these treatments, then as a last resort, laparotomy and the necrostectomy is being done. So it's not the part of early intervention. So 1, 2, 3 and 5, these are the lines of intervention as a set of initial. Now remember, initial. So we have to choose only those statements which will be done initially. So 1, 2, 3 and 5. So that's the answer. Okay, a 28-year-old patient presents with abdominal pain. Which of the following statements about the abdominal examination is false? So let us see the choices. Rebound tenderness shows underlying this is obviously true. Cullen sign and Gray Turner sign, again very easy choices. All of you know Gray Turners and Cullens are seen in the acute hemorrhagic pancreatitis or some kind of hemoperitoneum like splenic rupture, etc. Cullens is around the umbilicus, discoloration around the umbilicus, so this is again true. Gray Turner is discoloration in the flanks due to retroperitoneal hematoma, this is again true. Palpation should start in the area of pain, that's the false statement. This is a very common teaching. Examination of abdomen in a case of abdominal pain, you should always start from the virgin area, from the non-pain area, and then gradually proceed to the pain area. If patient has pain in right iliac fossa, never start from the right iliac fossa, always start from the left iliac fossa and then gradually proceed towards the right iliac fossa. So that's a false statement. This is again very easy question. In a trauma patient, the whole body CT scan includes all of the following except basically the primary survey. All of you know the steps of management of a trauma victim: primary survey, secondary survey and tertiary survey. Primary survey is identifying and managing the immediate life threatening injuries and a quick assessment of the patient that includes fast, that sometimes also include quick whole body CT scan. But in whole body CT scan, we do not focus on entire thing, entire body. We only focus on those areas which can have an impact on life. So life threatening injuries. So head is definitely a part of it. Brain injuries, all of you know, EDH can be life threatening. Cervical spine is again very important part of primary survey. Abdomen, again hemoperitoneum is a life threatening and part of the primary survey assessment. Upper limbs, extremities, injuries, they can be managed at a later stage. So extremities are not all that important in the primary survey, they can be left for the secondary or the tertiary survey. So that's not the part of whole body CT scan assessment in the primary survey. Now this is again a repeat question. Last year also this was asked. A 24-year-old patient is brought to emergency after assault. This is the injury scene. Now the question itself, again without looking at the image, question itself tells you the answer. Crushing of the hair bulbs. Crushing of the hair bulbs is classically seen in split laceration. Even the choices are not very close, right? Had it been split, stretch, laceration, so those could have been close choice. The choices here are not close. You can easily make it out. It's not a chop injury. All of you know chop, cutting through with a heavy sharp edged object like an axe, right? Or it's not clean cut looking wound. The edges are bruised here, rag margins, the edges are bruised, they are not clean. In a clean cut incised wound, the edges are clean and they are not bruised. No bridging. Here you can see bridging between the tissues, which is again a feature of laceration. Avulsion is degloving injury, separation of the skin fold, which I'll show you. So it's a clear cut, straightforward split laceration, right? So I'm not going to into this, I have already told you. Well, let me show you the pictures. That's a clean cut incised wound. As you can see, the edges are clean looking, they are not irregular, they are not bruised, there is no bridging between the tissues. That's a separation of the skin flap, as you can see here. That's the avulsion injury, degloving injury also. That's a chop, the separation complete with the impact of the sharp edged heavy object. Okay, so as I have told you, hair and hair bulbs are crushed in lacerations, whereas in incised wound, hair bulbs are not crushed. The edges are not bruised in incised wound and there is no bridging. Okay, so now we move on to the next question. A 20-year-old patient of RTA comes to emergency with respiratory distress. Chest X-ray shows pneumothorax. All of the following form the anatomical landmark. So it's a straightforward asking about the boundaries of safety triangle for chest tube insertion in the form of a clinical situation. So let me show you the picture first. So that's the safety triangle, right? So that's the apex of axilla, that's a transverse line at the level of nipple, horizontal line. The inner border is lateral border of pectoralis major, the lateral border is anterior margin of latissimus dorsi. So pectoralis major, latissimus dorsi, the line, horizontal line at the level of nipple and the apex of axilla. So very easy, there is no mid clavicular line involved here, right? So apex of axilla, infralateral border of pectoralis major, anterior border of latissimus dorsi. So that's the site for chest tube insertion, right? The mid clavicular line, second intercostal space, that's the site for needle insertion, not the chest tube. Needle thoracocentesis, needle aspiration, that's the emergency. Like a case of tension pneumothorax comes to you, immediately you have to decompress before the chest tube is inserted for the definitive management. So you just quickly insert a needle to deflate, reduce the pressure, hemodynamically patient gets better. So that's the second intercostal space in the mid clavicular line. Okay, now this is about again the oncological outcome based on the lymph node excision. Which of the following cancers are incorrectly matched? Read the question carefully. Incorrectly matched with the minimum number of lymph nodes required for the pathological staging. Now this is not one system question, 4 different cancers from 4 different places. So they have been taught many a times and in our content videos also. for resection of any cancer, how much should be the extent of lymph node resection? How many number of lymph nodes are needed for minimum pathological staging? So let me tell you again, for gastric cancer, the minimum is 16, more than or equal to 16. For colon cancer, it is correct figure, that is 12 minimum needed. Gallbladder, minimum lymph nodes needed are 3. Breast cancer, minimum lymph nodes needed are 10 for the correct pathological staging, right? If say you resect 8 lymph nodes in the breast cancer, in the axillary lymph node dissection, that's the insufficient specimen. Okay, so the incorrect, we have to choose incorrect. So incorrect are 3 and 1. So 1 and 3. So that's the answer here. Okay, now this is again very easy. Which of the following are the advantages of laparoscopic cholecystectomy? Means laparoscopic surgery. Increased duration of stay, this is false, rather duration is reduced. So that's a false statement. Early return of physiological function, that's true. Faster recovery, better cosmesis, true. Less post-operative pain, true. So the choices 2, 3 and 4 are true, and the definite advantages. So that's the answer here. Okay, next question. This is about thyroid. A 60-year-old female is having a large goiter. She is planned for surgical resection. Which of the following drugs can be given preoperatively to the patient to reduce blood loss during surgery? Again, relatively straightforward, right? Okay, let us look at the choices. Propranolol, you know, it's a beta blocker that's used for thyroid surgeries or thyroid disorders to control hyperthyroidism and to control the sympathomimetic symptoms of raised thyroid hormones. So one purpose is to control the sympathetic system, the symptoms, the manifestations. Two, it also inhibits the peripheral conversion of T4 into T3, which is more active form. So this is mainly used in hyperthyroid situations before the surgery to correct the thyroid functions. Okay, propyl uracil is anti-thyroid drugs. This is again useful for the hyperthyroid situations. Potassium iodide, or more popularly known as Lugol's iodine, that's a solution of 5% iodine made in 10% potassium iodide solution. So that's a common Lugol's iodine. Now Lugol's iodine or iodide, again it helps in suppressing the thyroid functions, but it additionally also helps in controlling the vascularity. So that's the answer here. Iodides or Lugol's iodine is given preoperatively before the thyroid surgeries in where a lot of bleeding is expected, particularly in malignancies, right? So to reduce the vascularity. Hypertonic saline doesn't have any role in thyroid surgeries. Okay, so answer is potassium iodide. This is again absolutely straightforward question. The easiest of all again. This is based on the assessment of a breast lump. Triple assessment. Female patient with breast lump was suspected to have cancer, breast carcinoma, and all of the following investigation should be done as part of evaluation except. So answer is PET-CT. PET-CT is not a part of triple assessment. The triple assessment for any breast lump, it includes clinical, histological and radiological parts. So let me show you. So triple assessment for breast lump: clinical in the form of history and examination, imaging in the form of ultrasound or mammogram, histopathology either with FNAC or core biopsy, and we get the diagnosis, the diagnostic accuracy, the positive predictive value is more than 99% in all the cases. So PET-CT is a part of staging. PET-CT is done to look for the distant metastasis that comes later, right? So that's not part of routine triple assessment for the breast lump. Now match the following techniques of biopsy with their respective indication. So again, this is not like a copybook question. You will find it any book or anywhere straightforward written like this, right? But with a little knowledge, basic concepts of the procedures, the types of biopsies, you can very easily solve this question, right? Let me show you. So left side are the situations. So soft tissue lymphoma, it's a lymphoma. Right thigh 8 into 4 centimeter. So it's a big size. 8 centimeter is quite big. Right thigh lymphoma. Let us look at the choices. Wedge. Wedge means cutting and removing a block. Why? Why unnecessary cut it? Right? So not needed. Core needle biopsy can be done. So wedge biopsy is not at all indicated. Core needle biopsy can be done. USG guided FNAC. Had it been simple FNAC, I would have taken it. But FNAC also gives you a cytological diagnosis. It's a lymphoma, suspected lymphoma. So we need to, biopsy is a better form, right? So FNAC alone is not sufficient. Plus ultrasound. It's a tumor in front of you in the thigh. You can straightforward take an FNAC. You don't need an ultrasound for it, right? So this is again out. Excisional biopsy, it's a large tumor, plus not all lymphomas require surgical resection. So this is again out. So A is 1, right? So very easy, as I told you, just apply the basic principles. Second, marjolin ulcer on the dorsum of the foot. It's an ulcer, so there is already a wound, right? So a wound, no FNAC is not needed, excisional biopsy is not needed, core needle biopsy. It's a wound, so best is take from the edge, take a sample of tissue. So wedge biopsy. This is straightforward, right? So B is choice 1. A was choice 2. B is choice 1. Okay. Now choice C, cervical lymph node. So cervical lymph node, suspected lymphoma again, size important. Neck lymph node, suspected lymphoma 1.5 centimeter. So we are left with two choices, ultrasound guided FNAC and excisional biopsy. So out of the two, looking at the fourth choice also, solitary thyroid nodule 2 centimeter. So in a thyroid nodule, obviously you will not go for excisional biopsy, right? You will go for a FNAC first, label the diagnosis, and then go for a definitive surgery. So solitary thyroid nodule, the correct answer is ultrasound guided FNAC. And for a small size cervical lymph node, best is just remove it, because again, like I told you, for choice A, easy. It's a suspected lymphoma, so FNAC alone is not sufficient. You need a biopsy. So best form of biopsy for a small lymph node in the neck, remove it. So excisional biopsy. So that's the answer here. So C is 4 and D is 3. So that's the answer here. So A2, B1. So that's the answer. So easy. Just look at the size, the location, the kind of the lesion, the nature of the pathology, and then look at the choice of the biopsies. Okay, damage control surgery includes all of the following except. It's very popular DCR, DCS, DCO, damage control surgery, damage control resuscitation. These are done for the management of the trauma victims, right? So the answer here is definitive repair, damage control. So obviously definitive repair will be done at a later stage. The decontamination, resuscitation, controlling bleeding definitely included in damage control surgery. Let me show you the various terminologies. ETC is early total care, which is a routine care. TCS is damage control surgery, prioritize emergency, and task is tactical abbreviated surgical care. These are the similar terminologies used against DCS. So DCS is damage control surgery. These are directly from Love and Bailey. So that includes controlling the bleeding, controlling the sepsis, protection from further injury. DCO is damage control orthopedics. So some additional orthopedic steps are included. Resuscitation, hemorrhage control is same as the previous one. Decompression is again similar. Decontamination and fracture splintage because it's orthopedics. Now DCR, damage control, so they are overlapping, only the terminologies differ, the steps are overlapping. So treat the acute traumatic coagulopathy, permissive hypotension until bleeding control, limit the use of crystalloids and colloids to avoid dilutional coagulopathy, and damage control surgery to control bleeding and preserve physiology. So the obvious answer, nowhere it is, it includes the definitive repair. Okay, all of the following are true regarding familial adenomatous, again a very important topic. Familial adenomatous polyposis, which is the hereditary form of colorectal cancers. The other one is HNPCC, that is hereditary non-polyposis colorectal cancer. So adenomas are seen, there is 100% risk of lifetime risk of colorectal cancers. Now this is autosomal dominant, both of them, HNPCC and FAP, they are autosomal dominant disorders. FAP is caused by mutations in APC gene. APC is adenomatous polyposis coli gene, and it's a tumor suppressor gene. So deletion of tumor suppressor gene, that is APC gene, is associated with cancer. APC inhibits WNT signaling, so that is true because increased WNT pathway signals are associated with cancer, and if you delete the APC gene, that will cause enhanced WNT signaling because it inhibits, right. Now FAP cases are associated with congenital hypertrophic retinal pigment epithelium, right. There I have already told you, so that's true, this is true, 100% lifetime risk of colorectal. It's very easy, even if you don't know the rest of the choices, just one thing you need to know, FAP is an autosomal dominant, it's not autosomal recessive. So that's a false statement about familial adenomatous polyposis. So the next question is, a 60-year-old male presented with abdominal pain, so 60-year abdominal pain and obstipation with distension. X-ray shows, that's the most important clue, coffee bean appearance with scoliosis and hip arthritis. The most likely cause of the symptoms is image based question. So that's the coffee bean appearance, right. So classical coffee bean appearance, again a simple straightforward, n number of times this has been taught and this has been discussed. Coffee bean appearance or inner bent tube appearance, this is classical of sigmoid volvulus. So the answer here is large, but it's a case of large because there is obstipation, abdominal distension, old age, and you can't see any small bowel here, that looks differently, I'll show you the pictures, and it's a coffee bean appearance, classical of the that's because of iliosigmoidal knotting, and classical of sigmoid volvulus. The other choice is obstruction because of fecalith, we can't see any fecaliths here, so that's out, it's not a small bowel obstruction, clear cut. Large bowel obstruction due to cecal volvulus looks different. From the right iliac fossa there is a single loop, distended loop seen, I'll show you the pictures. These are the other three pictures. That's a large bowel obstruction, that's because of inspissated fecal matter, that is fecalith. This is a classical small bowel stepladder pattern, valve conventis you can see, and the erect film you will also see the air fluid levels, that's a cecal volvulus. So if you compare it with this, so there are not two loops like a coffee bean, it's a single loop distended, that's a cecal volvulus. So that's how it looks like, so easy to make out. Now that's a question from pediatric surgery. Correct order of steps of the surgical correction of hypospadias. So we have to put them in the correct order. Let us see what are the steps of hypospadias. So penile degloving and correction of the ventral chordae, that is orthoplasty, step 1. Then reconstruction of urethra, that is urethroplasty, step 2. Then in between comes the meatoplasty, the correction of the meatus, that's step 3, and then reconstruction of glands, that is granuloplasty, is step 4, and finally the cosmetic skin coverage and creation of a circumcised penile shaft, right. So the correct order is the orthoplasty is step 1, and then the urethroplasty. So after 2 it is 4, so that's the correct one. Then the meatoplasty, and then last is the granuloplasty or glans plasty. So this is about the, so the questions were very easy, and they were straightforward, many of them. The images were very easy to recognize them. And remember, just go through these questions, and all the questions have very high likelihood of being repeated in your subsequent exams. So that's it. Thank you.